So third major topic, moving on from getting to the heart, getting large bore access, now closing this large bore access with dry closure techniques to minimize bleeding. All of us know when we use closure devices without occluding the vessel, even with two operators on board, we end up with pretty messy bleeding. This technique here is showing two angioceal closure devices, and whatever device that you use, you usually have to have a very good technologist or a second operator to hold pressure, and even with that, you lose quite a bit of blood. So multiple techniques have been developed to kind of inflate a balloon, in that what you see here on the right side is an up and over technique where the operator places a sheath with an 035 wire and a balloon to occlude the vessel while the closure is being undergone. So there are three choices for that: either the contralateral femoral technique, like what I showed on the previous slide. The second one is becoming more popular, the radial to peripheral technique, especially with the availability of radial to peripheral sheaths, which are at least 119 centimeters long, allow us to kind of take a final angiogram with the least morbidity of a radial access. But there's also, we describe the ipsilateral dry closure technique. From you don't need an extra access, you save time, you save equipment, and you save fluoroscopy and contrast by doing that. And this is the slide that Doctors Tayal, Walmuth, and myself published in the Journal of Invasive Cardiology, which shows that the placing a balloon from the ipsilateral sheath, inflating the balloon at 2 to 4 atmospheres, which is kind of picked at a size of 1:1 relative to the external iliac artery, and then pulling the sheath back over the shaft of the balloon while cinching down the perclose device, like what you're going to see in that video. So here the technologist is pulling the large bore sheath over the shaft of a balloon, which is already inflated in the external iliac artery, and you can see how dry that closure is. You had a 14 French arteriotomy site, and now it's almost non-bleeding after the perclose is cinched down. And then subsequently, the balloon is deflated and removed over the wire. We do not usually encounter any resistance from the perclose suture itself, since the arteriotomy site is relatively large, and subsequently either a second closure device or manual pressure is withheld. And this is not only performed in the femoral access, but also the axillary access, and makes our life much easier and leads to much less bleeding peri-procedurally. Moving on to limb perfusion, which is the fourth topic of peripheral vascular skills for the cardiologist facing peripheral problems. We know for sure that limb perfusion issues and limb ischemia increases mortality tremendously, exponentially. Those patients who face acute gangrene in the ICU, who are already sick, facing cardiogenic shock, have a 60% mortality risk as per the ECMO literature. And for that, we usually recommend antegrade access of the femoral artery, usually prior to the placement of the retrograde large bore sheath. But of course, there are some situations where the large bore sheath has to be placed in an emergency for cardiogenic shock. And like in this case, we had to place the perfusion sheath after the large bore sheath is placed. It's very important to use a ultrasound and maneuver that ultrasound device under the large bore sheath. We usually have to get relatively lower access in the superficial femoral artery. And you can see in the video on the right that the angle should be shallow to minimize the kinking of the sheath, and as well as the circuit occlusion from those acute angles. Plus, it is important to use a sheath that's braided, that is less prone to kinking in these kind of situations, especially those patients going to have those sheaths for a few days in the ICU. Bypass options: whenever we have the perfusion sheath and the receiver sheath in the superficial or common femoral artery into the superficial femoral artery. The donor sheath is either the ipsilateral retrograde sheath side port with the ipsilateral external femoral bypass. We can also have the option of using a contralateral retrograde common femoral artery access as the donor sheath and connect that with a male-to-male connector to the side port of the antegrade perfusion sheath. Thirdly, there's a complex technique involving up and over, placing a catheter and a small 4 French sheath within a large bore contralateral retrograde common femoral artery sheath and using the internal femoral bypass, which has the advantage of not having any external components, but is quite complex, requires a lot of skills, and requires fluoroscopic time, dye, and obviously complexity. And finally, we described the land-to-hand technique where the radial sheath is the donor sheath connected to the side port of the perfusion sheath, and the radial sheath was the original radial access sheath for coronary angiography and intervention, and now is the donor sheath for perfusion of the leg. And this is a real-world example of this land-to-hand technique. And finally, what comes to people's minds mostly is complications, how to deal with them. This is a video that shows coiling of the inferior epigastric artery, which is a rare complication of vascular access. You can see here extravasation from the inferior epigastric artery, which leads to retroperitoneal hemorrhage. On the right, you can see a video of how to actually prep that. You place the coil microcatheter inside the delivery microcatheter, and this is advanced. Obviously, every coil has its own information for use manual, so obviously it's important to get familiar with your equipment, and it's always important to have a few coils on the shelf to deal with emergencies, and knowing how to perform that not in an emergency setting would be ideal if you want to practice on the bench or on simulating with simulation with the help of the manufacturing companies. We describe here also how to deploy a covered stent in the axillary access once extravasation does not cease after removal of a large bore access. This patient required 10 minutes of angioplasty with 5 minutes times 2 without a resolution of the extravasation, and a covered self-expanding stent was deployed from an ipsilateral radial sheath, a 6/7 French radial sheath to stop the bleeding. Also, what we face sometimes in the peripheral vasculature is a dissection, like you see here, microvascular access. Angiogram revealed evidence of a pretty substantial dissection in the external iliac artery. So an up and over contralateral common femoral artery access was obtained, a sheath angiogram was obtained in an antegrade fashion, and then a self-expanding stent was deployed, leading to resolution of the ipsilateral left external iliac artery dissection, which was caused by the actual access sheath. And one of the techniques also to learn from your colleagues and partners and other vascular specialties is retrieval of non-thrombotic material. These are the different ways that we can use to get that. It depends on what you have on your shelf, but it's important to familiarize yourself with one or two of these techniques and get good at it, especially in emergencies. And finally, improving operator vascular skills requires hands-on bench training, especially if you did not receive training in this vascular territory, leading to adequate management of distal vascular dissections, thrombosis, perforations, calcifications, tortuosity, and large bore sheath. I would say one of the most important things that taught me is having great partners with great experience and collaborating with people who have more experience than you in that field, and having them on your side whenever one has a complication or a problem getting to the heart. And thank you very much for allowing me to share my TCT presentation this year. Please feel free to contact me through these methods if needed.